like, is this the mailman school of public? What? Where am I? What? Huh? Who is this? What? This is the mailman school of public health. You're in the right place. You know, you're not going to remember much after graduating from college because the way that all courses are taught are exactly the same, right? They require you to cover a large range of stuff, and then there's a midterm exam, and then right before the midterm exam you like cram, and you're up all night drinking coffee, and then you go and you take the test the next day, and you're like, and then you're like trying to stay awake, and then you go home and you take a nap, and then you go out and get drunk and kill any brain cells that were like just forming, and then you like go back to class again and you learn more material and you have your final exam, right? That is not how we learn things as human beings. How do we learn things? Well, you know, like we're born from our mothers, and then almost universally, and then we are, unless you're from Guangzhou, that's a different story. You're a crisp baby, that's different. So we're born from our mothers, we enter into the world, and then we have stimuli, right? We're stimulated by things in our environment, and we interact with those things like a word, like mama, baba, whatever. That word keeps coming at us, and it keeps coming at us, and it keeps coming at us, and that's one thing you never forget. If you forget to call your mom mama, then you're like, you're past due. You're like, it's over. If you forget that. We keep hearing the same stimuli over and over again. And actually, neuroscientists have figured out how this actually works. So, you know, we're exposed to concepts. That information is consolidated into the temporal lobe, but it just sort of sits there. Then we're exposed to concepts again, the same concept. But hopefully the second time we're exposed to it, it's in a slightly different way. It's a slightly different context. It's a slightly different place. And then we have to use that concept, and we have to look at it from a different angle. And it's that point that that idea gets consolidated into your brain. We don't learn things by reading a book, taking exams, sitting in some stupid lecture and hearing some bozo like me like blabber at you with flapping his gums. We learn by playing with ideas. So in this course, I'm going to do things a little bit differently. I mean, I know you guys, it's difficult to learn anything after being this far into the core, because your brains are like, if everybody's like really quiet, you can hear it. And at this point, you're like, I can't do this anymore. It's like you're in the desert, and there's water off in the horizon, and that's winter break. But the closer you get, the more you realize that it's just a mirage. So, I am not going to give you a test for this class. And in return, no, I'm just kidding. You know, I really believe that learning is on you, but I'm going to present this material in a way that you are going to remember stuff 5 years after this class, right? So I'm going to ask you to work with the material a little bit in class. You're going to see things repeated a little bit, but you're going to get it from different angles. So, you know, and this is really easy in this particular kind of class. So I've designed this class in a kind of a unique way. So you guys have already had health econ and health systems, and you've had all this other stuff in the core, right? So you have a foundation of knowledge that's buzzing around in your head, but you need that to consolidate it. You need it to get it here, right in your brain, right there. You want it there, there. So you want it there. How are we going to get it there? Well, we're going to take some of the ideas that you've already learned from Spare's course and Talgross and all that stuff, and we're going to look at it in a new way from an international comparative system standpoint. But I'm also going to use a core set of principles throughout this whole class, and those core sets of principles are all you need to know. That's all you really need to know for comparative health systems and for health systems and health policy and all this stuff. It's going to be a core set of principles. And the way you're going to see these principles used is you're going to see them taken up and broken into pieces and put together into different health systems all over the world. It's that simple. So what we're basically going to do is sit around with a big puzzle and take it apart and then or put it together, you know, have a picture, and then your uncle's going to come along and step on your puzzle and break it up, and you're going to be, ah! And then we're going to put it back together into a new puzzle and a new picture, but using the same pieces. That's the basic idea of how this class is going to work. So we're going to take these core principles, apply it to Ghana, which, believe it or not, has a national health system. We're going to apply it to Canada. We're going to apply it to Thailand. And I'm going to listen to you guys a lot, too, in terms of the material that you want covered, specific countries that you want covered, kinds of information that you want. So give me the feedback. But mostly you're going to get a few basic health systems from around the world in the high-income, middle-income, low-income context. And you're going to take what Michael Sparrow taught you and what Tal Gross taught you and these principles that I'm going to teach you and reassemble them into any pieces, into a new piece, a new picture. Any questions about that? So part of this process, the other thing that you guys, what I'm hearing from students when my advisees and everybody, and every time I ask them, like, how's it, everybody's like, well, it's, you know, I'm taking lots of exams. I guess it's fine. But you're not getting much of a chance to write. The other thing you're not really getting is much of a chance to present. So what I would like you guys to do is to either write a brief on a health system that you pick and you want, or to present on a health system that you like and you want. Now this is kind of scary for some people, right? To stand up in front of a room of 400 students and talk. How many people are scared by that idea? Okay, so anybody who's raised their hand, you should do this assignment and not write. I have a photographic memory. I saw all of you guys. I remember who you are. Seriously, challenge yourself. This is a big chance. I know you're like burned out and it's the end of the semester and everything, but this is a chance to really challenge yourself and pick up a new skill. Public speaking, for instance. It's a chance to do some writing. You can do one or the other. You can do whatever. This course is about learning. And this is a bad time to be learning because at this point you're like, I just want to get the hell out of here. But it is a chance. It is an opportunity to learn. And our university is more than $20, unlike Father Guido Sarducci's 5-minute university. It's more than $20, so get your money's worth. This is a chance to do that. So remember I said we were going to do some repetition? This is the repetition part. We're going to tackle the same concepts in many different ways, tackle the same concepts many different times, and learn a new health system each day and apply these concepts to the health system. So everybody should understand this by now, no matter how fried you are. Except for those of you who probably dropped Molly last night or did something fun. Everybody else has got it. Everybody's got it, right? Okay. So this course is about self-motivation as well. I mean, you could just sit here and actually, the way that I've designed it is that I want you guys to be able to sit here in your class and be like, and still like come out with something useful. But if you're really self-motivated and really engaged with this stuff, you're going to do really, really well in this class. Okay. So for the paper presentation, I do recommend that foreign students who are not native English speakers do the paper, just because you guys don't have very much chance to write. And the way that I'd like to work with the TAs actually is that you guys sort through this, and if a student has some challenges with grammar or things like that, this is a great chance to work with that student and help them. So if you're not a native English speaker, you know, save some money and don't pay somebody to write your paper for you. You won't be penalized for your writing. We can work with you a little bit, me and the TAs, in terms of improving your writing. This is a good chance to do that. What you're going to be graded on in the paper is not the grammatical structure, though this is critically important for you in your job for the rest of your life. What you're going to be graded on is your ability to pull out those concepts that I mentioned right before, these core concepts that we're going to learn over and over and over again. You're going to want to be able to pull out, the TAs are going to be able to pull out those concepts in the paper and see how you applied it to the health system you're studying. Okay, so what's the paper assignment? Pick a country, any country. It could be a country with a functioning health system, can't think of one. Or it could be a country with a non-functioning health system like the US or India. Clearly non-functional. So you can pick some country and apply these principles to it. By the time you start writing, you're going to know what they are. The assignment can be 1 page, it can be 2 pages. You don't have to have references. Yeah?
Sir, I'd just like to clarify one thing. In India, there are states where you have really good
Kerala.
Yeah.
Name another one.
No, that's where I'm from.
Okay. So outside of Kerala, yeah, you've got to. Even in Kerala, there are challenges, but there is at least a functional health system and schooling system. So, any other questions about this assignment? Okay. Somebody's going to have some kind of a question. You don't have to do references, though it would be good if you referenced the papers that you do. In the School of Public Health in general, you should always use EndNote. EndNote is free. Everybody know about EndNote? Everybody know where to get it? Or Notero or whatever. Just Google Columbia EndNote and it will come up, and then you download it for free. The reason why EndNote is so important in your career as graduate students is because everybody uses it. I'm not pimping this package, although I do own stock in the company as a disclaimer. I'm just kidding. Any referencing software, the advantage to these software packages is that you can just reformat it on the fly for any journal. And it makes it very easy, and you build the library of all the references that you know and like to use. So, you know, it will help you a lot. If you have to do these things by hand, you're going to waste a lot of time. So use EndNote. It integrates with word processing programs like Microsoft Word. It's awesome. Okay. Any questions? Ready to move on? Okay. So I do want to give you a sense of what the paper is actually going to be in terms of these core concepts. And what you see here are a couple of things like Bismarck and portability on this slide. Does anybody know what I mean by Bismarck or know what I mean by portability? I listened into Sparrow's lectures, and I'm not sure that you're getting all these concepts. Yeah? Bismarck was what? Yes, it was the first healthcare system. And did it involve private insurance plans or? Yeah. So the idea is basically the idea behind a Bismarckian system is that you have governmental regulations on what are called sick funds, which are basically like a systemized way of having private health insurance at the government level. Ooh, there's another one of these portals here. These are really cool. Have you seen these things? You just go in there. Has anybody seen me, John Malkovich? This is the 8th and a half floor. So what I'd like you to do is to take these basic concepts and apply them in the paper. So you're going to be talking about how healthcare is delivered in Tanzania, and you're going to be talking about whether it's a system that looks like a national health insurance scheme, a beverage scheme, Bismarckian scheme, etc. So, what is a health system? Well, a health system is actually an amalgamation of very attractive mixed-race people wearing medical outfits, all in the same room smiling. A health system, the way that the World Health Organization conceptualizes it, is an agglomeration of the way that I'd like you to think of a health system is basically anything that produces health. So an example would be the occupational safety regulations, environmental protection agencies internationally, things that safeguard the health of populations. So these are things that don't necessarily have anything to do with the Ministry of Health or Department of Health or the CDC or any of those things. A health system is just a mix of all these things that improve health. And you learn from other classes in the core that health is determined both non-medically, right, and medically. What do we know about the medical side of things? Is health insurance, how many people here, after having gone this far in the core, how many people would say that health insurance is definitely going to improve your physical health? Some people have not been paying attention. I'm just kidding. No, I mean, this becomes an ideological question, right? It ultimately becomes an ideological question. We've had 2 randomized controlled trials in this country that have shown no benefit on physical health for health insurance, right? So we've randomized people to Medicaid. Remember biostats, epi, randomization, gold standard. Everybody on board with that? No confounding, no whatever. No benefit to physical health. And no matter how you spend that study, there's no benefit. Rand health insurance experiment, way back in Father Guido Sarducci's time, randomized people to health insurance or no health insurance. No benefit. There was some benefit amongst people receiving antihypertensives. One of the interesting things about the Oregon health insurance experiment is that people got more care. So in Oregon, you were enrolling people in health insurance randomly. They were getting more care. They were using more care. They were getting more drugs. And they weren't getting any better physically. So it may be that health insurance doesn't improve your health. So after I've just flapped my gums, how many people would say that they now believe certainly that health insurance improves health? So we still have some diehard. We've got Trotsky and Lenin over here. Well, actually, I actually think that health insurance is a good thing in the name of health for a number of reasons. So one of the things that Oregon did was that it showed that mental health outcomes improved. Right? So depression levels went down. If you talk to people like Heidi Allen, who is one of the chiefs in the study, they'll say, well, yeah, people were getting more antidepressants. They were getting diagnosed with depression. But that can't really account for the massive drop in clinical depression that happened with health insurance. Anybody have any thoughts about if it wasn't for all the pills that people were popping to get rid of their depression? Sorry, it's going to take a few pills. If it wasn't for the pills that people were getting, what could have accounted for the better outcomes with health insurance? Yes. The stress, yeah. So people were a lot less stressed. It is really stressful not having health insurance. And so, these people did, the researchers, did they did qualitative interviews along with a quantitative data collection. And they found that people who won health insurance in this randomized controlled trial were much happier about life in general. And they were asking them, well, what were some of the experiences you had as an uninsured person? And people would say things, well, well, I broke a leg, my leg, but I was afraid to go to the emergency room because I was afraid of getting charged for that. And this person who broke her leg and didn't go to the emergency room, she said, look. And she stood up, and one leg was had a big bulge in it because it wasn't a clean fracture. So the bone was, basically bulging out of her leg. Health insurance provides something that's extremely important, even if it's not health. Health insurance is actually designed to provide social protection, so financial protection. That's what it's really about. It's not really about making people healthier. It's not supposed to be about that. It's supposed to be about pooling risk and then using that money to pay for people when they get sick. And we learned about moral hazard, right? And that kind of stuff. But that's the core function of health insurance, is to pool risk and pay for it. The cool thing about a program like Medicaid is that you can pool risk from everybody. So even if you've got no cash to put into that risk pool, everybody's following me what a risk pool is, right? So it's a big pool of cash that you throw money into, you pay it out when people get sick. Right? The cool thing about Medicaid is you can take money from rich people and put it in that same pool. Right? So even if the poor people can't afford to get health care, you still have a pot of funds. You're taxing people and putting it into a big pool and then paying out. So health insurance is a lot more than making people healthy. But what does make people healthy? Does anybody have anybody want to volunteer what you think you would do if you were given, the health budget is $3 trillion, right? $3 trillion. If you took $1 trillion, somebody came along and Obama came along and said, with his head turning, he said you could take that $1 trillion and spend it on anything. Would anybody, what are some ideas? What might people spend it on after having had the core? Yeah. Wait. Raising the minimum wage. Yeah. So raising the minimum wage will do something pretty impressive at the population level. It'll do a lot of things, right? One thing that it will do is that it will mean that you can work in McDonald's, and instead of making $9 an hour, you're going to make $10 an hour in New York. That's a proposal. You could raise it to 11. In parts of Europe, it's been raised really high. So it was raised by 30%. And the businesses stayed in business even after the wage was raised that high. So what's raising the minimum wage going to do for your health? Well, it's going to allow you to buy a lot more alcohol and cigarettes, which it will do. It will also allow you to potentially move to a better neighborhood. It may allow you to move into a higher quality housing. Maybe you live near a freeway exchange, right? And there's a lot of pollution there, and you really want to get out of there. But you can't, because your job sucks. Now you can't, because you have raised minimum wage. It's going to have all sorts of unintended consequences, though. Remember, policies affect people, not populations. Everything you've learned so far is about epidemos, on top of populations, right? These policies, when you're thinking about health policy, you're no longer an epidemiologist. You're now thinking about people. And people are impacted by policies in a lot of different ways, like these people here. People are very, very different. Some people live near freeway exchanges. Some people have a neighbor that's been threatening them with a knife. Some people have a drug problem. It's going to influence all of those people very, very differently. So actually it turns out that from trials, from basically natural experiments in which Indian reservations, casinos, give out cash randomly to people who are, basically randomly, to people who are card-carrying members of their tribe, and not to people who are not card-carrying members of their tribe, which is basically random. They find that people who get these large amounts of cash do funny things. Some people, car crashes increase, for instance. But pathology in the home tends to go down. If you think about this in a population level way, you're just looking at the way that things move, right? You're looking at the way that needles move. Is income going up? Is alcohol consumption going up? These kinds of things at a population level. But what's really happening is there are lots of things that are happening to individuals within that population. And there are lots of things happening to your environment. So it actually turns out that raising the minimum wage is going to have some adverse effects on your neighborhood. Can anybody think of one of those? What's it going to do to your mom and pop businesses? Depends upon where you are, right? In a lot of neighborhoods, what it means, what raising the minimum wage means, is that only Gap can compete there. Only Starbucks can work in that neighborhood. Walmart. So when you raise minimum wages, it tends to churn businesses a lot. So big corporations can handle higher wages better than mom and pop businesses, which tend to be running closer to, a break-even point. That happens in some places. In other places, it doesn't. Another alternative to raising the minimum wage is something called the Earned Income Tax Credit. In the Earned Income Tax Credit, you don't have to worry about those problems like business churning and things like that. What it does is it gives people an incentive to work like a minimum wage. It pays you money if you're working on top of your regular wages, right? So now you've got an incentive to work if you weren't working before, and you've got a higher income up to a certain point. So that's another option that you can do. You want to think about all of the nuanced effects that these health systems policies can cause. Occupational safety saves lives. The EPA saves lives. Welfare probably saves lives. We're not 100% sure about that. It definitely does some weird things to health. But it creates all sorts of things that you might not think about or might not expect. It has influences on family size. It has influences on your economic growth of the whole nation. Environmental regulations will take people who are in the workforce and make it impossible for them to get a job. Why? Because it puts regulations on businesses and slows down the economy. And as a result, people become unemployed. So all of these policies in a health system work together in this big swirling morass in ways that produce unpredictable outcomes. So we have to be careful when we're thinking about health and policy within a health system. So our health system is everything. It's this big swirling morass of things. If you change something, all sorts of unpredictable things are going to happen. And then within that whole morass of things is something called a healthcare delivery system. And the healthcare delivery system, which you have been told, is a system by which people are receiving some sort of direct clinical services. So that's the difference between a health system and a healthcare delivery system. Now we can sit here all day and think about policies and in a health system and how they might fit together. And actually, I find that hugely fun. So that wouldn't be bad for me at all. But this class is going to be about healthcare delivery systems. When we talk about healthcare delivery systems, we want to be thoughtful about what these healthcare delivery systems are doing to that big mix of things, right? How's a healthcare delivery system influencing the economy, right? So let's stop right here for 1 second. Okay, let's keep going. No, I'm just kidding. Let's stop for 1 second and ask ourselves, okay, well, Peter just told me all this like weird stuff about what happens when we raise the minimum wage and earned income tax credit, right? So minimum wage, and maybe some people are going to drink more, but other people are going to have less pathology at home, and maybe Walmart's going to come into my neighborhood. Maybe we can do earned income tax credit instead. Like there are all these different things that sort of happen, right? What would the equivalent be for a healthcare delivery system? It's having a healthcare delivery system that's organized by your government a good thing for your economy? How many people would say yes? And how many people would say no? This is the problem with graduate school and particularly mailmen. Is that like if you're a conservative, you're like up there in the corner like cowering because your classmates are like, come out of the closet, wherever you are, up there. It actually turns out that having a healthcare delivery system, which people call rational in the terms of healthcare policy, is actually, in general and in most cases, in fact, probably good for your economy. Unlike necessarily, like in the short term, having environmental regulations or occupational safety regulations, which are going to slow you down but improve your well-being in your country. It's going to make people healthier and happier, but it's going to make you less employed. Having a healthcare delivery system is probably going to improve your economy. Does anybody know why that is? Yeah. I'm going to be quick. Healthier workforce, yeah, so healthier workforce. Mm-hmm. So, but one problem with that idea is that it may be that healthcare delivery systems don't actually improve people's health, right? So we know from the Oregon Medicaid experiment that people were getting more screening, more treatment, but their cancer rates weren't going away or going down at all. Their blood pressure didn't go down at all. Their blood glucose didn't go down at all. So, but I think you're right, actually. I mean, I'm challenging you, but I'm not challenging you. I think you're actually right. I think it does make people healthier. It does make the rate of depression go down, and it makes people less stressed out. So it makes your workforce healthier. Any other thoughts? Yeah, that's huge. So, you know, if back when cars were made in the United States, actually it's only Toyota and Fiat that make cars in the United States anymore. Chrysler makes their cars in Japan. No, that's not true. They make their cars in China mostly now. But it actually, for the cars that are made in the United States, it costs companies more to provide health care to their workers than the companies spend on steel. That's because cars are no longer made of steel. No, I'm just kidding. They are still made of steel. It is true. So if companies are spending so much money on healthcare, it's going to make them less or more competitive in the global marketplace. Less, obviously, right? So to the extent that a country can have a national health insurance system, it can offset those costs unless the government is just taxing the company to pay for insuring its citizens, right? So it actually turns out that Sweden, which has one of the, best quote-unquote healthcare systems in the world, also has one of the lowest tax rates for corporations in the world. What they do is they just tax the workers. So if you're in Sweden and you're Volvo, which is now owned by Chrysler, I think, but if you're in Sweden and you're working for a car company, that car company is only paying 20% in tax, and then you're paying your employees generously, and then the government's taxing those wages and then paying for health insurance that way. So that's actually a pretty good system for making your businesses more competitive. There is a key thing about healthcare systems that you kind of learn already, which is this. Almost everybody here has a Apple computer. I own stocks in Apple. There's my display. No, I don't. Actually, I probably do, but I don't know. I don't own any stocks. So almost everybody has an Apple. And then we have some HP. Yeah, we have an HP over here and a few other brands. And when you went out to buy your computer, for those people who don't own Apples and are just mindless drones buying what everybody else buys, for the other people, I put like a little wooden thing on my iPhone. It's a unicorn. No, I own Apple products too. So for those of you who are buying computers based upon some sort of rational criteria, you're looking at things like what? Your memory, your hard drive, the quality, this and that, right? So you're looking at things that you know something about, like 1 gigabyte is more than like 100 megabytes, and like a terabyte is good, or whatever. Like you have these basic parameters around. Even if you don't exactly know what a terabyte is, you have some idea about what that means when you're buying your computer. You might also look online and like read a CNET review and say like, this brand is better than that, it's good quality, good customer service, blah, blah, blah. So you have good information about the products that you're purchasing. You have pretty good information about the products that you're purchasing, right? So unless you're an Apple owner and have skinny jeans and a fixed gear bike and live in Williamsburg, those things aside, you're making decisions about your computer based upon some sort of rational criteria, right? And so what happens is that companies that can provide things at a high quality and low cost are going to survive, and those that don't are going to die. But in health insurance, it's not exactly like that. Okay, so I'm gonna randomly challenge somebody. I won't challenge the TAs because they're all like, I've already been through this class before. So imagine, do you have any medical background? Yes. Yes? Okay, forget it. Well, even as a pharmacist, actually, I put you back on the hook. So even as a pharmacist, like suppose that you developed your doctor told you that you had a Gilbert syndrome, which is actually a real thing. Right? Let's pretend like it's not. Let's pretend like it's a serious thing, right? So you're going to go online and you're going to try and get information about that disease because you're like, oh crap, I'm dying. And then you're like to Google stuff, and you're going to read everything that you can, like, and you're going to end up on sites with like information about crystal healing and like, water purification, who knows. But at the end of the day, you're going to have some information about your disease, but one thing you won't have is, how do I determine the difference in quality between one provider and another? How do I actually ascertain that, like this guy or this woman is worth more than that one? It's imperfect information. It's very, very tricky to get a sense of which providers to go to get the highest care. You might go to Columbia Medical Center. That would be a mistake. Just kidding. So you don't have good information. And on top of that, you don't really care about price. Why don't you care about price? Like your computer could cost $40,000 and you don't care. Why? In medical care. Yes, exactly. You want to maximize your health, right? So you don't really care what you pay. The benefit is what you're worried about, because, like, if it's your computer, you could pick like the fanciest computer that's out there, right? And just buy that. Why? Because somebody else is paying for it. Who's paying for it? Everybody in that risk pool, right? So your employer is paying for it, blah, blah, blah. You don't really care how much it costs. That's a concept called what? Anybody? Yes. Yes! Moral hazard. So that's a concept called moral hazard. And what it indicates is that there's market failures in health systems. And when there's a market failure in a health system, like moral hazard, imperfect information, information asymmetry, all those things that Tal talked about, when you have these problems, you have a market failure and you have serious cost issues, right? So like you could open an MRI suite and you could, hi, and you could open an MRI suite and all of a sudden, like you've opened your MRI suite and there's half as many patients to go around, so what do? Charge twice as much. Why not? And buy like a crappy scanner, like from, like you can go to like the junkyard and get your scanner and nobody's going to know the difference. It's not like any of your patients are going to come in and be like, oh, the Plasmatron 6000. Right? So it doesn't matter. And what happens is that you get cost escalation and cost escalation and cost escalation. One of my students in the executive program was a chief executive officer of a small pharmaceutical firm. And he got to be the chief executive officer by making the company viable, making it a lot of money. They had one product, and that was a 10-milligram pill. And his innovation was to take that 10-milligram pill and repackage it as 5-milligram pills and charge the same amount. And he did that because people were breaking those pills in half, like doctors wanted to prescribe less. So he just made a 5-milligram pill, charged as much as a 10-milligram pill. Their sales went through the roof because people were breaking their 10-milligram pills in half before. Now they were selling many, many more pills because they were individually packaged. That's market failure. Lots of cases of this. Anybody been following the news about this? Hillary Clinton's all up in arms about it. What's going on? The patents expired, yeah. Yes. Yep. So raise the cost of a pill from $1 to $750. Whatever. It's the healthcare system. Somebody else is paying for it. You're not going to call your insurer and say, or your insurer is not going to call you and say, sorry, we're not paying for your treatment because it now is $750. You're going to be like, oh yeah, well, I'm going to go to my HR office and we're going to drop you as our healthcare provider, right? So this is a market failure. This is not the only case of somebody raising the cost of one pill from $1 or $13.50 to $750. There are lots of cases of this, particularly recently. So there's a huge decoupling between reality and what things actually cost. So when you have a national health insurance system in place within your healthcare delivery system, what you're doing is the government is stepping in and the government is saying, you cannot charge $750 for that pill. You can't do it. If you do it, we'll just make the pill ourselves. That happens. So the government can fix those market failures. Do you want the government making your computer? What would our computers look like if the government made our computers? This whole room would be filled full of tubes. And like our television screens would be like in Brazil, like with John Buttle, like little things and magnifying glasses, right? Governments do things very, very, very inefficiently because they don't have to compete against anything. And because, taxpayers demand that lower wages are paid to managers. There's lots of reasons why governments are terribly inefficient. But they still will do a much better job at delivering health care than a private market will because of moral hazard, because of information asymmetry. This is really, 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 really important. I am not a raging Bernie Sanders, pot-smoking socialist up here telling you that we need universal health care. We need universal health care because $3 trillion of health care expenditures are, that proportion of our GDP is growing. We are in trouble because we are financing a market that's totally out of control, and the ACA is helping a little bit, but not enough. If you let your health system go, it will consume you. It's like a huge black hole. It's like a red dwarf. It's about to explode and suck everything into it. Healthcare systems are terrible. They're terrible things. They're terrible for your economy. And they're especially bad if they're in the free market. But we have to have healthcare delivery systems because we break our legs and we have like liver disease, like Gilbert's disease. And we have evil pharmacists who are going to raise the cost on your... No, I'm just kidding. We have to have a healthcare delivery system. So we have to put up with a lot of government inefficiency. The government is not going to do as good of a job as a free market in making your computers, but it's going to do a much better job at delivering healthcare. This is not a radical concept, but there are lots of people in this country who are arguing that that is a radical concept. It is not. Okay, so healthcare delivery systems will make things run more efficiently. There are a lot of different models for healthcare delivery. You can have, government paying for everything. You can have, private insurance. You can have government insurance, but private providers. You can have a lot of different models. I think at the end of the day, it doesn't matter what kind of government universal health care system you have that much. It does matter, but it doesn't matter that much. What really matters is that the government's in there regulating stuff. This is all up for debate. I'm here. I'm listening. We can argue it or debate it as much as we want. Let's see if this
sorts of public health services, such as main drainage and water supply. Everyone makes use of these services, and everyone pays for them. Refuse disposal is another of these services. And so is street cleaning. These are all public health services, but the new Health Act proposes to organize personal health services in the same way. There have been many personal health services, but different kinds of financial arrangements. Morning, George. Morning, Charles. Morning. Some people could afford them. Others could not. Some places were well off for hospitals. Others were unlucky. This new health service will be organized on a national scale as a public responsibility. The cost of the service will be met from rates, taxes, and national insurance, and so everyone will pay for it.
Thought was a catch in it.
And everyone will benefit from it. When you're ill, you won't have to pay for treatment.
I don't have to pay the doctor now. I'm on the panel.
Yes, that's true, but your wife and children aren't. The panel system covers only half the population. And it doesn't cover hospital treatment or a lot of other things, does it? Now, just suppose you fall off your bike. Suppose your brakes give out. You might have concussion as well. new health service would cover all this. Now let's consider it from the family viewpoint. Suppose your wife falls ill suddenly.
But my woman is ill. Strong as a bloody nose she is.
My mother's can't afford to be ill. I'm not insured. Just a minute, Dux. Besides, I can't take time off from my job.
Well, that's just it. Now let's see how the new Health Act will actually help you. The local council will have a new duty to provide home nursing, health visiting and home help services, and you will be able to call on them.
Okay, so I just want to stop this for 1 second. I know it runs a little bit slow, but I want to point out that the key distinctions that the NHS was making when they started and made this video. One of them was that they were already providing health services under a health system like sewage and sanitation, right? They talked about that. This health system, they haven't even really talked a lot about clinical care. They've talked about financial protections, right? So you don't have to pay like a few quid, which is like $4 if you get in an ambulance. But what they're talking about is a sense of well-being and security, and now they're talking about what this actually means at the household level and family level, which is visiting nurse services and things like that. This is a pretty different conceptualization than we're probably used to in the United States.
Maternity and child welfare services will be improved. And finally, to prevent illness, you'll have the advice of your own doctor. If you're ill, you'll have specialist services if you need them, without worrying about the cost.
That's more like it.
How does the whole scheme work?
Well, suppose we see how it is at present. Hospitals were built haphazard according to the varying foresight and resources of many different authorities, with extremely patchy results. Reorganizing will take time, but at the end of it, the country will have the sort of hospitals and other services it needs where they are needed. The family doctor will usually work in his own surgery, as he does now. But special health centers will gradually be established as building allows. He'll be backed up, your doctor I mean, by organized hospital and specialist services for the really difficult cases, a lesson we learnt during the war.
Sounds a bit all right to me, but just a minute. Where the road coming?
Right here. Let's have a practical demonstration. Off you go to the doctor. You have some unusual illness which can't be diagnosed. He'll no doubt wish you to see a specialist. In hospital, you'll be under observation. This will include X-ray if it's found necessary. They may decide you need special drugs or blood transfusion. And they'll be able to make use of the Path Lab to find out what's wrong and how best to make you well.
Glad that's over. But look here, how about the people who don't want to use this service? Take old George up the road, for instance. Bet your father a penny he won't want to have anything to do with it.
Well, let's find out.
this new Health Act?
No use to be heard, Ben.
Now, wait a minute. Just suppose, only suppose, mind you, you fell off that ladder. What would happen?
I should call my doctor and have a private room in the local hospital.
All right, George. If you want to pay private fees, that's your lookout. No one's forcing you to use this service. But suppose instead of a simple broken leg, you have a complicated break. And suppose you have to spend months off sick. And suppose you don't need just one doctor, but another expert's opinions. What's the answer to that? With this new act, you're covered against things like that.
I say, thanks a lot, old man.
It's all yours, whenever you want it, with your own choice of doctor. And that goes for the whole family. The scheme is comprehensive. It's not only to help you when you're old, but to help to keep you well. And of course, the younger generation will stand to gain the biggest benefits of all.
So, that's a little bit lengthy, but I think it's, whoops. I think it's useful to illustrate how these systems were sort of first conceptualized. So in the post-war period, you had your first real serious effort at total government health insurance system, and this is what we were talking about before. This is one of the big models. So there's Bismarck, beverage like Coca-Cola, Sprite, and Pepsi. There's a Bismarck system, there's a beverage system, and there's national health insurance, and then there's free market. Those are basically the four major conceptualizations for how these health systems work. The UK system is what is classically a beverage system, and that was a notion that you can just do everything rationally by design from the top down using taxpayer dollars to pay doctors that are working for the government. So everything's within the government system. And this particular model has a lot of advantages. As we saw from the video, in a free market system, what's happening is hospitals just go where there's money, right? So you have hospitals, and lots of hospitals in rich neighborhoods. It's great to be a doctor on the Upper East Side, right? So there were lots of hospitals established in those kinds of neighborhoods traditionally, historically, because it was a free market system. So wealth and hospitals were two things that went together in the old days. Under this system, you can put clinics wherever you want. So you want to build clinics not where the money is, but you want to build clinics where people are sickest. So we know from the socio-medical determinant system, section of the course that low-income people are a little bit sicker than wealthy people. Much sicker than wealthier people, right? So the need is greatest in the lowest income communities. That's where you need to build the clinics. And then you can build rationally a referral system so that you have many different neighborhoods with clinics that refer to nearby tertiary care centers, right? So you've got primary care to specialists to hospitals. Everything's neatly packaged. Everything's geographically tidy. Cuba has a system like this. Kerala's system, when it was first planned, was a lot like this. State in India. These systems are, in theory, conceptually advantageous relative to any other system because it's a top-down system. You can control everything as a government. So you can control all these market failures. And you're motivated to use the rest of the healthcare system, not the healthcare delivery system, but the rest of the healthcare system to make your population healthier, right? So the government is highly motivated to do things that will reduce chronic disease in the population, reduce accidents, reduce injury, because they have to pay for all of this stuff. Everybody on board with that? That's a beverage system. We heard earlier about the Bismarckian System, which is basically a regulated system of health insurance. So it's a little bit like the U.S. in that, you know, your employer by sector will have a insurance pool, a risk pool that's private, and the doctors are private. But there's a lot of regulation, and the government also has its own insurance plan that looks very similar, almost identical to all the other sickness funds, all the other insurance plans, regardless of whether they're in the private sector or public sector. So everybody's plan looks pretty similar. The payouts are pretty similar, and that's a huge advantage. So what happens in the U.S. system when you just have chaos, health insurance? This is a free market system. It's a Bismarckian system. It's it's all of these systems all in one thing. What happens when you have a mix of systems, a mix of providers, and total chaos in terms of payment? Do you need a lot of people to run that kind of a system? Yeah, you need a lot of people, right? You need a lot of people. Because you have to have somebody in the doctor's office that's trying to figure out, well, does Aetna cover this? Does Blue Cross Blue Shield cover that? Oh, this person's on Medicaid. Oh, this person's on Medicare. This person's on the Indian Health Service plan. This person's in Veterans Administration, but there's no VA hospital nearby, so I can't bill this person at all. We don't know what to do with this person. It's a mess. There are all these providers, and the information is all over the place. So, in a centralized system, you can, in theory, have one set of electronic medical records for everybody in the country. In a Bismarckian system, you can do that too, because you have the government saying you have to use the same electronic medical record system. In the U.S., it's just chaos. So you've got a lot of different systems, you have a lot of different payers, a lot of different providers, and a lot of people. So by some estimates, upwards of 30% of this system is just administrative inefficiency. It's just all these extra people that are hired in the U.S. to do all this stuff. You don't need all those extra people in a system like this. This system doesn't work well. I mean, there's nobody in the UK that's going to say, this system works flawlessly. It's a terrible system. But in healthcare, terrible is a relative term. So even though it's a terrible system, it's working a lot better than the United States system. So in the United States, you've probably heard these statistics before, or I know you've heard the statistics before because I had to listen to all those lectures. But in the United States, our public sector, what's our public sector? Medicaid, Medicare, what else? Throw me some stuff. What's that? Food stamp is part of the whole overall system, but how about actual medical care, healthcare delivery providers? IHS, yeah. What else? Yes. So we have all these different systems in the public sector. Crazy. None of the systems work together. Medicaid is very different from Medicare. They're trying to create some sort of seam between those two things that Michael talked about with DSRIP. The Indian Health Services. All these systems are totally different. They don't talk to one another. They don't know what the other one's doing. They can't coordinate care. They can't, you can't go from one to the other. It's a disaster. In the public sector in the United States, we spend more per capita than the National Health Service in Great Britain spends. But those systems only cover 20% of the population. In other words, if we had the NHS here, we could cover everybody at a fraction of the cost of what we're spending now. If we're spending $8,000 per head to $10,000 per head in our public sector, and the UK is spending $3,000 per head, you can do the math pretty easily. $2,500 a head. It used to be much smaller. The difference used to be much bigger until Blair came in and injected all this money into the system that went nowhere. But you can see that there's a huge degree of inefficiency associated with business as usual in the United States. Okay, so if you have one system, you're going to be in much better shape. Okay, so The national health insurance scheme is a beverage system, and the Bismarckian system is private-private with a huge layer of regulation. You have a lot of variations on that. So in Switzerland, for instance, you have just a regulated private insurance market that's not all pooled together into these things, into sickness funds. In Japan, the government just sets prices for everything in the private health insurance system. So you have a lot of different variations on how all these things work. And then you have a free market system, which is, out-of-pocket expenditures. These kinds of systems exist in the lowest income country contexts, usually, and that just means that you're pre-health insurance, basically. Like, if you want to see a doctor, you better get your corn and trade it for your medical services. So in some places, in some low-income contexts, the doctors will actually list, 10-minute medical exam, 1 chicken, 20-minute medical exam, 1 goat. So you have your prices and some sort of, everything is out of pocket. And it's whatever people can come up and scrounge to pay for the medical care. Okay. So those are the key types of systems that you see internationally. When we come back in the next class, we're going to start to break these systems down a little bit, and we're going to start to talk about what are the components within each of these systems, Bismarckian, beverage, etc. National health insurance systems, like the Canadian system, where the government is public insurer, but the doctors are all private. We're going to talk about some of these systems as examples, and then we're going to be talking about the key building components of each of these systems within each of these larger categories. So Bismarck, beverage, national health insurance, out-of-pocket. Within each of these, we have a whole bunch of different components, which we're going to start to talk about next time. Okay, any questions so far? We only have a few minutes left. So I want to return to the very beginning of the class and talk one last piece of pedagogy. So one thing I think that I would like to accomplish with this class is to return to the healthcare system question outside of class. So you have readings from a really badly written textbook that I put together, which is free online on Courseworks. You guys put it up there, right? Yeah. So it's not worth $80. It's not worth $5. It's not worth much at all. The background story of this book is that I wrote it with my ex. And when we broke up, she wouldn't let me edit her half of the book. It's terrible. But I do know the content of the book, and it's built around health systems globally. So it's built around international health systems. And what we can do with that book is we can pull out the information that relates to everything you've learned. Health disparities, race and health, global health policy, global governance. All these things are going to be in the readings, and they're going to be running sort of parallel to the lectures, and I'm going to call them up in the lectures. So today it was pretty straightforward. The readings talked about things like payments, capitated payments, fee-for-service, all the stuff that Michael Sparrow talked about. I don't need to talk about fee-for-service payments a lot because you already know what that is. But what you're going to hear about with respect to fee-for-service payments is stuff, when we're talking about specific health plans like Taiwan, and Thailand uses a capitated payment system, which you've already learned about. But this is a chance to take that information and read about it in the book, and then pull it out and apply it to these health systems, but not just apply it to these healthcare delivery systems in different countries, but also to apply it to your knowledge about how health systems work. And what I want to do is to create a kind of gestalt, which means everything all together, which is a name for this phenomena, which is a name for things that happen in healthcare systems. what this reading section of the class is going to do is it's going to pull everything together for you in this class. And when you take the final exams, which are coming up at the end of the semester, hopefully all of that information will start to come together as a whole. Because I think that one of the things that you're kind of missing in this class is how do you think about non-medical determinants? How do you think about health disparities? How do you think about global health? How do you think about ethics? How do you think about all of these things within the context of the broader health system? And how do you apply a lot of those things to a healthcare delivery system when you're designing the healthcare delivery system? This is not, well, this is totally esoteric and BS and whatever, but it's not esoteric in the sense that it's not practical. It's super practical because under ACA, all these health systems, including Presbyterian, including Mount Sinai, including every system around here, has to think not just about how they're delivering care, but the context within which they're delivering care. They have to think about the healthcare system as a whole, because what we're finding is that people are going out, right, and they're using drugs intravenously, and they're getting line infections and endocarditis and going into the hospital, and then getting state-of-the-art treatment with antibiotics and monitoring, and discharged 30 days later back into the community, only to start using again, and only to come back into the hospital. What's the point of having the hospital if people aren't getting the care that they need to help them kick their drug habit and come back into the hospital? We have to start thinking about how these healthcare systems interact with the healthcare delivery systems. That's everything you've learned in the core. And that's where the money is now. So, you know, New York is putting $10 billion into this question of how do we integrate the healthcare system and healthcare delivery system so that things like that stop happening as frequently as they do. Okay, any questions about that? Okay, we are done. Hi. How's it going?
I just kept raising my hands about the health insurance not improving physical health. I guess more from my personal standpoint. I'm curious, was the organ studies, are they in the readings?
Yeah, I can actually ask.
Well, the thing too is when you listen to the recordings of lectures and people come up like this, it's like your conversation might not be private, it might be like recorded for 600 people to hear off the course.
Right.
Anyway,
yeah, it's only embarrassing if you're farting or something like that. Right. I could. What I can do is give the TAs the Oregon and the RAND health insurance studies and submit and pass those around. I think that health insurance is critically important. Don't get me wrong. It's just a question of how much it produces physical health.
And I'm like the poster child for it.
Excellent. Well,
for your well-being and for your, I can give you story after story of things I didn't do because I had health insurance, things that I screwed up, and the type of work I did, which was massage therapy. I even worked for a big corporation. They wiggled their way around so they didn't have to give us health insurance, which they do.
Yeah, I've been there too. I've been in insurance too.
Yeah. Most people show up with health insurance.
Yeah.
So I see what it does to us and what, so anyway. Yeah,
well, what you really need to see is you need to see the qualitative and quantitative results side by side, because the qualitative results are all what you're saying.
Right.
People with compound fractures, all sorts of things, not getting care.
Well,
but does it
how
show
long
up?
people were going without care? Going 1 or 2 years without care is one thing. Going, 2 years is quite a lot. And then going without care when you're in your 20s versus your 40s or 50s is another thing altogether.
One point that I didn't make strongly enough is that people are, part of the problem is that this is an average. So people are getting too much care and getting hurt by the system, and people are getting too little care and hurt by the system. Yeah. We can go into that. Actually, we should start the next. Can we have that conversation with the class?
Yeah.
Awesome. Oh, great.
Just a clarification point. You mentioned this before. This Bismarck beverage
national
And
health insurance, and free market.
And free market. Okay.
Yeah.
And insurance, that's not the same thing as the government delivering
The national health insurance is like the Canadian model, where the government is a public insurer, but the doctors are all private.
but France is a mixture of both public and private providers.
France is like Germany in that it's a Bismarckian model, basically. Yeah, and they don't cover 100%, so there's private insurers that cover that top it off.
Okay.
But we'll talk a little bit about France, but not that much. But we can, everything's a mix. Yeah.
Thank you.
Sure.
Hi. In regards to the assignment.
Yeah.
Okay, so it's either a paper or we do a presentation, right?
Yeah.
But I'm not really sure as to, for example, I don't want to do it on Jamaica because that's where I'm from.
Uh-huh.
So then what would I be focusing on? Jamaica's healthcare system? Like what exactly?
Yeah. So
what about Jamaica's healthcare system should I focus on?
So what you're going to get in the next lecture is a set of principles. So one of them is going to be like, is it portable? Can it be moved from can it be moved from people with, in Kingston outside, or can it be moved from people in Jamaica who travel? Like, is it usable? That's portability. Is it universal? So is everybody receiving
the same type of healthcare benefit?
Healthcare benefit.
So when you say portable, as far as like what do you mean movable? Like from Jamaica to here? Like how that wouldn't work?
Portable just means that it's in the strictest sense. So if you're in Kingston and you're in the countryside, will that work? Will you get coverage? So that's one concept. Another one is if you leave Jamaica and you're traveling in Barbados and you hurt yourself, what happens?
Okay, would your insurance cover you?
Yeah.
Okay.
Yeah.
Okay.
So these are concepts that we'll talk about, and then what your job is going to be to take these concepts and apply them to the Jamaican healthcare system.
Okay.
Does that make sense?
Yeah. So for the presentation, how is that? Like, how long would we get to talk? Would we have to have
7 minutes.
Okay, and we would have to have like a PowerPoint.
You don't have to, no.
But then what would we?
You could do a Michael Spare and just.
But then what would we submit to you?
You don't have to submit anything. You'd be graded based upon your presentation.
And to see if I touch all those main points. Okay,
yep,
and then
easy.
That is, but then how is 400 people going to present on the same day unless we're going to do it in more than one day?
It's going to be in lectures. Based upon my experience, so we're in 4 cohorts, so it's 100 people in each
cohort.
And 2 of them are in the same class at any time. And based upon my experience, there's going to be about 1% of the class that's going to want to present, and it's going to be 7 minutes long. So it's not going to be everybody lined up and presenting. It's going to be people who are interested in a particular health system and coming up during their regular lecture and presenting. And I'm going to give an example of that on Thursday. There's a student that's going to come up and present.
Okay. And then as far as the paper component, how would we formulate that? Like it would basically be the same information in the paper if we didn't do the presentation.
Yeah.
Okay.
Pretty straightforward, pretty easy.
Okay.
It's just like
the guideline is also on Courseworks.
Yeah.
Okay. All right, thank you.
Sure.
Hi, I'm Sarah Dugan.
Hi.
And this is Andrea.
Hi.
Nice to meet you. We're actually the new e-board members for the SNAP chapter here. And so we're trying to put together an event about national health insurance. And I know this is maybe kind of early, but wondering if you might want to talk at it or be involved in something
when's the
like
event?
That. We don't know yet. We're
we're just very early stages.
Okay. Yeah, I'd be happy to. The one thing you have to keep in mind is that I disappear in December, and then I don't reappear until March.
Okay.
Yeah.
Where are you going?
I'm a turtle.
What? Where are you going in December?
I go to Thailand. I have an NGO there.
Oh, okay. So before December or after March?
Yeah.
Okay. Great to know. Well, thanks for your lecture. I'm really interested in hearing more about national health insurance. I guess I went to the PNHP conference and they talked about Thailand a little bit.
Oh, yeah.
But definitely hearing more about like how that will could translate to the U.S. or what a system like that would look like in the U.S.
Right. Yeah, yay. Cool. Thailand is a great system, so we're going to cover that a lot.
Yeah,
a little bit.
Yeah, they had a presenter who was, I guess she was from Thailand and presenting, but she seemed, I don't know, it didn't seem like that great. there seemed to be a lot of problems with it, but I guess
there are. But I mean, for a country with such a low per capita income, it's a pretty impressive system. Yeah, so everything is relative. Like every
Right,
system
like you're
sucks.
saying, yeah, it's like how terrible is it? I
How
guess,
terrible is it?
but-
Yeah.
Yeah. Well, nice. Well, thanks for your lecture today.
Sure.
Thank you.
In the aisles. I didn't know if they give it to you. There's like some plastics in there.
Wow.
Yeah.
It looks fancy. I don't know what it is.
There's no glasses, just plastics and chopstick. But
Okay.
I thought someone would do it.
Okay, thanks.
Hi. My name is Taja.
Hi,
Nice to
Taja.
meet you. I have a question about the presentation.
Uh-huh.
So, does it have to be from another country? I would like to present on the Alaska Native Tribal Health System.
Yeah. That's
And
fine. Yeah,
that would be great. Awesome.
That would be awesome.
Yeah, I'm
So
Alaska
you would-
Native.
Oh, you are? Okay.
Yeah.
Yeah. I'm 25% Sigali. I'm not card carrying, but whatever.
Yeah, and I would thank you. Yeah, because it's so different from IHS, from even the brief, like
Yes.
one paragraph that people read
Yeah.
in their
I think
careers.
that's awesome. That would be really, really cool.
Awesome. I'm so excited then.
Yay!
Thank you.
Yeah, and so since you're presenting, what we need to do is figure out when, because we'd like to do it as it could be as early as next week if you want.
Woo! I guess how is it? I was looking on Courseware.
Just 7 minutes.
Just 7 minutes. Okay. And do we get a freedom to do it like Prezi, or does it have to be like PowerPoint? Anything?
Yeah, you
7
don't even
minutes,
need a
anything?
presentation.
About the whole health system as a whole, or how it differentiates from the U.S.
What I would do is just come up with a 7-minute presentation that you think forms a narrative.
Yeah.
And covers some of the basic concepts.
Okay.
So you can actually design it like you would like to design.
That would be great. Yeah. No.
There's a student
Really
that's going to come
exciting.
in on Thursday and present that will show an example of how you can.
Okay, and should we work with the TAs about scheduling?
Yeah.
Okay, I will definitely reach out to the lead
Yay.
TAs. Thank you so much, Peter. I'm super excited.
Yay.
Hi.
Hi.
I'm Anthea.
Hi. Nice to meet you.
I just had a question. I guess mine was more like a clarifying question between the presentation and the paper. So if we do a presentation, are we still turning in some form? We're not. We're just.
No.
It's just going to be based on
Yeah.
what we present. Okay.
It's basically very like this. There are going to be very few people that do poorly in this class because it's iterative. It's very iterative. So I just want to see that you really get how these basic principles plug into whatever it is that you're talking about.
Okay, so it's just either or, and we don't have to turn in something.
Yep.
Okay, and then if we're presenting, are we presenting to everybody in here?
Yep. Well, half of it, because from now on it's like 2 cohorts in one class.
Oh, okay. It's not going to be all of us.
I don't think so. No.
Okay.
I wish, but I don't think so.
Okay, that won't be too bad. I think it's too bad. Do you recommend presentation over a paper? Like, what do you?
It depends upon if you have a hard time speaking in front of people, then definitely do the presentation. But if you feel like you need some writing, that's the risk. That's the risk. Yeah, you'll probably get more out of the paper then, because if you like talking in front of people, that's a skill that you already have, right? Yeah.
So just sort of depending on what you feel
Exactly.
like you could benefit most from.
Exactly. Yeah. It's not like you're not going to get an A whichever way you do it. So you should do it to build your own personal skill set.
Okay. All right. Thank you.
Sure. Hi.
How are you? Let me introduce myself. It's Rosa. I'm the director of the Office of Educational Programs.
Okay, great.
So
Yeah.
we're here because we're going to make some announcements around certificates.
Okay.
So we just want to set up. I don't know if you're done yet.
Yes, I'm done. And this belongs to somebody who's in this class.
Okay, I'll make an announcement.
Thank you.
So somebody lost it.
Yeah. It's earplugs and cup links or something.
We can close this down. Is that okay?
Yeah.
Okay, great. Thank you.
Let me actually log out. Really?
That
thank
video
you.
that you played in the beginning of your lecture.
The Father Guido Sarducci?
Yeah, when he was talking about students not, retaining all the information.
Right.
It was a good video.
That's a neuroscience video, right?
Yeah. I've never seen it though. So.
Right. See you. Bye.
Pleasure meeting you. Hi, how you doing?
Oh, such nice mood lighting.
I know. They just ended a class.
Ah,
We're just making some announcements.
sure.
Certificate announcements.
Yeah, no, I came to listen to those announcements.
Okay, great.
I'll hang out.
Okay. volumes are.